The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and welcome to today's webinar. How are you managing diabetic foot ulcers? Evolution of therapies across the continuum of care. Before we get started, I would like to go over a few items so you know how to participate in today's event. You have joined the presentation listening using your computer speaker system by default. If you would prefer to join over the telephone, just select telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation, and we will collect these and address them during the Q&A session at the end of today's presentation. Today's webinar is being recorded, and you will receive a follow-up email within 24 to 48 hours with a link to view the recording. I would now like to introduce Dr. Paul J. Kim. Over to you, Dr. Kim.
Thank you, guys, and thank you guys for joining. I want to welcome everybody from south of the border. It's hard for me to think of it in those terms, but I know that this is for Wounds Canada, which I appreciate inviting me to give this lecture. I really like talking about wounds in the context of the diabetic limb because I think it's a very challenging problem. So we're going to cover a lot of material in the next hour. I want to talk about setting the picture of the difficulties that we face in treating these patients, but also discuss some options for treatment that include some very well-known and probably commonly used therapies in Canada. I just want to give you a background. I'm currently in the Department of Plastic Surgery. I'm the professor in the Department of Plastic Surgery and Department of Orthopedic Surgery at the University of Texas Southwestern in Dallas, Texas. I may have met some of the people on this phone call when I was at Georgetown University Hospital, which I was there for the last 10 years, and I recently made a move to Dallas. I'm also the medical director of the wound program at the University of Texas Southwestern Medical Center. Although my passion's in the diabetic limb, which is really, all of my work has really been focused in on that area, our team manages wounds throughout the body, in both from a surgical standpoint and also from a conservative standpoint. What I want to do is break this talk up into two real pieces. The first piece is the outpatient management, which is often the case in most places that I've visited across this world, and also the inpatient or the acute management piece as well. So I'm going to try to tell a story here that sort of ties in the reasons why we do what we do and the challenges that we face and some solutions that we may have. Again, the diabetic foot is a very difficult problem, and it's not just a problem in the US, it's not just a problem in Canada, it's a problem globally. And we need to face this head on before it gets to a point where we can't manage it. I understand the issues in Canada. I've had a chance to visit there on several occasions, that there are unique challenges to the Canadian health system. But ultimately, for me, it's about patient care and improving the quality of life of our patients that we serve. And so that's going to be the focus of my lecture. Just for disclosures, I have research and consulting funding from KCI, Acelity, which is the sponsors of this talk. And I will tell you, and I'm very open to disclosing that I'm completely biased because this is a set of product portfolios that I use on a daily basis, and I firmly believe in them. And if I didn't, I wouldn't be doing something like this. And so I know that you all carry your own biases, experiences, training, and education, but I ask you guys to suspend your beliefs for just at least for the next 45 minutes or so, and try to be as open-minded as possible in thinking about using these kinds of therapies in the context of the healthcare system that you guys serve. This is the KCI disclaimer, which essentially says what I'm going to talk to you guys about is not necessarily supported by KCI. I'm going to speak from my clinical evidence, from my experience, because we all carry those biases in with us whenever we see a patient. This is my American disclosure. Yeah, we feel the same way. All right, so when I talk about wounds, I always start to talk about in the context of when I'm faced with a new patient, do they have the potential to heal at all? And that's a very difficult question to answer. I think the way that I think about it in terms of an equation is there's a 1 in the numerator, there's bacterial perfusion and tissue mechanics in the denominator, but it doesn't end there. I think the driving factor for healing, whether a patient responds or does not respond to a certain biologic drug or device, is the host. And the host is very complicated. What does that mean? The easy thing to think about is their comorbidity profile, but it goes way beyond that. It goes to, for example, their socioeconomic status, their nutritional status, their age, what kind of support system that they have at home, what kind of access do they have to the healthcare system. All of those things are driving factors. Another piece of it that's of great interest to me is their genomic profile. If we could somehow genetically profile our patients to identify responders and non-responders to certain specific therapies, I think our success rates would go higher. Whenever I see a wound, for example, in the outpatient basis, I think of this pyramid. On the very bottom, there's a chronic ulcer. On the top, there's a healed ulcer. How do you climb that mountain to that peak of a healed ulcer? Well, you do those things that we just mentioned. You maximize the perfusion regardless of what part of the body you're in. You address the tissue mechanics or biomechanics in the lower extremity, and you have biofilm and infection control. That gets you to about a 50% healing rate. And you think it's sort of a low number, but those are pretty low standards to go by. If you can do those three things, even adequately, you get about a 50% healing rate, and that's what the literature tells us. I've read the literature, and if you look at any comparative study where they do those three basic things, you get about 50% of your patients to heal. Then if you use some of these adjunctive therapies, a couple of which I'm going to cover today, it can raise that ceiling to another 30%, but there is a clear cap on healing rates or healing potential. That's about an 80% mark. 20% of patients that you encounter in whether it's in the outpatient basis or the inpatient basis, you will never be able to heal. And these are what I term as palliative wound patients. And often the goals for these patients are very different. It's not about healing them anymore. It's about making their quality of life better or improving their quality of life, keeping them out of the hospital, for example, preventing them from getting infected, for example, having them spending more time with their family and friends. It's a different metric of success than those other patients where you do actually have the potential to heal. For the rest of my talk, I'm going to talk about some drivers of care, and these concepts include economics, efficiency, and efficacy and effectiveness. These three E's drive care regardless of your location, whether you're in Vancouver, British Columbia, you're in Washington, D.C., Dallas, Texas, or you're in London, England. These things drive what you do and how you do it. So I'm going to break these apart and sort of piece it back together at the very end. Let's talk about economics. And specifically, when you look at Canada, Canada spends tons of money of their percent of their gross domestic product on healthcare. In fact, you're the 5th highest spender on healthcare globally. You can see the US on the far left, you can see where Canada ranks. And it's pretty interesting considering that the overall population, which I'll talk about in Canada, is relatively pretty small. This is a very expensive endeavor, $3.9 billion Canadian spent on treating wounds. Now, this is a very big number, and when people think about how many zeros there are, there's a lot of zeros, and you sort of gloss over and not even think about it. But I want to make it very personal for you, especially in Canada, where a huge percent of your tax dollars are taken out of your paychecks to pay for health care. You know, you're more socialized than we are in the U.S., although in the U.S. there are aspects that are socialized. But this is your money. You are paying for this. And so there should be some accountability on how this money should be used, especially in this space that you guys all cohabitate in. So you need to take some self-responsibility for this money. I refer to the population of Canada. It's relatively small. In fact, the population equates that of California in the United States. But proportionally, your diabetic population is fairly high. Your ulcer population is high as well. So there's a major problem in Canada. You know, there's a perception from Americans that Canadians are pretty fit, but it's simply not true. If you look at statistics about the proportion of diseases and disease processes that you have, it's pretty expensive. For example, Ontario, if you look at a diabetic foot ulcer and the treatment over the life course of the patient, it's about $619,000 Canadian dollars to treat and continue to maintain a diabetic foot and to prevent perhaps amputation or to get primary healing or to prevent reoccurrence. So it's not a cheap process. In the hospital, especially in the acute side, in the inpatient side, it's a very expensive endeavor, and this is true also universally. 320.5 million Canadian dollars to treat a patient in the inpatient setting. Being in the inpatient is not only costly, it's not a safe place for patients. If any of those that are on the line here take care of patients in the hospital, you know it's a dangerous place. There are lots of bad things that can happen to patients in the hospital. If we can keep them out of the hospital and spend less for it, I think that everybody wins. By the way, you may be thinking, well, yeah, we spend a lot of money, but we provide high quality care, and that's simply not true. If you look at the effective care, safe care, coordinated care, the cost of care, efficient care, equitable care, you guys rank almost dead last. US beats you as being the last, being in the last place. You know, Canadians don't do a very good job as far as providing a high level of care. So you're throwing a lot of money at the problem, but not really solving many problems. Now, one argument to this is to say, well, this is a complex problem. And these are complex problems. There's no doubt that these are complex problems because it's not just the wound, it's not just the leg, it's not just the foot. It's the patient who is very sick with diabetes, which is a relentless disease that affects every organ system in their body. And for me, when I see a diabetic foot ulcer, it's simply a sign of the disease. It's not the disease itself. The disease itself is diabetes. So unless we treat that first, nothing else that we do really makes a lot of sense. But unfortunately, right now, there's no cure. Management is poor, regardless of the new medications on the market. So we're forced to treat the symptom or the sign of the disease, which is the diabetic foot ulcer. Often, this is a major problem in the environment of a lack of blood flow or perfusion. And so when you have such profound vascular compromise, unfortunately, there's not a lot of answers to an attempt to salvage the limb. This is an amputated leg. X-rays. So if you look at the bony architecture, which is also something that makes things complicated, you wait a week on a patient like this, you can see significant disintegration across the midfoot. This is classic Charcot neuropathy. And this is something that sometimes when the bony architecture is so fragmented, it's not salvageable. When you have overlying soft tissue infection with underlying bone infection, this is a complicated problem as well. And again, this is not something that we can salvage. Here's an example of a patient. You look at the clinical slides on the left, you can see those little digits 4 and 5 are pretty black. They're probably not salvageable, but how about the rest of the foot? Is it salvageable? You get x-rays and you can see those x-rays look okay. The bony architecture appears to be intact. And then you get an angiogram, a lot of collateralization, but no real inline flow past the ankle. Here's a live case. If you've never seen an ankle disarticulation performed, this is a PTY1 resident in the month of July doing his first case doing an ankle disarticulation. We tend to stage these procedures on patients that get major amputations. First, we take the foot off, and we wait for the edema to go down, we wait for the bacteria to be flushed out of the lymphatics, and then we go back and we do a primary closure with the posterior flap. But you can see in real time an ankle disarticulation being performed by a first-year resident, and he's doing a great job, by the way. But he keeps looking up at me, just as a side story, keeps looking up at me, and I think he's nervous about doing this procedure. I simply ask him the question, is there something I can help you with? Do I need to scrub in? Is there some, are you scared that something will happen? He answers by saying, well, should we inflate the tourniquet? Well, the tourniquet is obviously not necessary since you look at the angiogram, there's really no flow. So I've showed you some major amputations, and you may be thinking that, hey, well, Paul's a pro-amputation kind of guy, and this is simply not true. Now, this is a quote from a friend of mine who is an amputee. He described this in a book that he gave me many, many years ago. And we're born with 2 feet, and one is not a spare. I take amputation very seriously, but I do think in the subset of patients, it is absolutely the right thing. It's the most efficient thing. It's the most economic thing. It's the most effective thing for those patients. Another piece of the complexity is the host, and I'm just going to go back for a second. This is a good paper looking at the Medicare population, which is the older government insurance program that we have in the United States, looking at their comorbidity profile. And if you look there, 82% of patients in the hospital at any given time in the United States have 5+ comorbidities. And if you have just hypertension, that's okay, but if you layer on hypertension with renal disease, with pulmonary disease and diabetes, then it becomes a serious problem. And these are largely what we see on the acute side. So our host is complicated and they're complex. Let's go back to the drivers of care. We covered the economics or the scope of the problem just a few minutes ago, and it's an expensive problem. And the argument has always been that it's expensive because it's complicated. I think there is some truth to that. But despite working in that environment, we need to provide some efficient processes to take that patient throughout the continuum of care and get them to full healing. Secondly, we're going to talk about efficacy and effectiveness. So in talking about those two concepts, I wrapped in two different ideas. Number one is when we think about any of these biologics, dressings, devices, drugs, we have to be able to differentiate between wound management and wound healing. I think they're two different things, and people tend to use them interchangeably, and I think that's an incorrect way to look at that. When you think about wound management, it's more, for me, palliation. For example, that 20%, you need to manage what? Their exudate, for example, is wound management. But wound healing is, the goal is to actually heal. And that, I think, is very different than trying to manage a wound versus healing a wound. The other part of this, using these advanced therapies that we're going to talk about, is this idea of time as tissue. And you guys have heard this before. Anybody who's spent any time in the wound space has heard this before about time as tissue. Well, what does that mean? When I see a patient for the first time, I have a clock that runs in my head that says, I'm already behind. I need to hurry to heal this patient, because if I don't, the risk of infection climbs exponentially, by the way, and the risk of admission related to costs also climb exponentially. So when I see a patient with an open wound, I must try to close or cover them and heal them ultimately as fast as possible. So to that end, I'm going to talk about some outpatient stuff. So outpatient, obviously there's some fundamentals that need to be done in the diabetic foot: offloading, debriding, just management of the wound exudate. All of those things are very important. In that spectrum of care is the spectrum of KCI products. And the two things that I'm going to talk about is Permagran and Prisma. How do these things work? Well, I think what happens, and people have to understand, when you have an opening in the foot, that is damaged tissue. It's as if you had just injured something in your body. You know, you get this inflammation and you get this healing or reparative process. But the problem with the diabetic foot is that cycle doesn't stop. It continues to circle the drain, if you will, and it can't seem to sort of bug out of that circular detrimental process. So I think that's something that we have to be cognizant of. Why does that happen? Number one, there are physiological changes that happen in the diabetic patient that create this circle of chronicity that they can't seem to break. The second piece of this is if it's in the lower extremity, it's on the plantar aspect, which is the majority of diabetic foot ulcers that are chronic, is you're putting weight on it. And I often talk to my patients about the fact that if we were living on the moon, you would never have this problem, because gravity is not our friend on this planet if you have a diabetic foot ulcer. And so it's chronically being traumatized. So you get this cycle of inflammation that delay healing. And part of this cycle of inflammation includes the release of certain proteins and enzymes and cytokines. And one of these is something called proteases. Now, proteases in the short term are important. You need them. It helps you heal tissue. But what happens in these stalled or chronic wounds is it continues to work and continue to be present in that wound bed. And then it becomes detrimental. They function to break down proteins, and there's two really important proteases. You guys have probably heard of these as well. Matrix metalloproteinases, which are the MMPs, you've probably heard people talk about that, and elastases as well. And there is an equilibrium that is required in the human body to heal anything. And there is an upset in this equilibrium that causes the chronic cycle of inflammation. And this is where something like these products can come into play, where it's called oxidized regenerative cellulose, the ORC. And what that does, it tends to equalize or create equilibrium in the wound bed by denaturing those proteolytic enzymes. And that is the magic of this kind of topical therapy. The indications are listed here. I think that you guys are probably familiar with the use of these in open wounds, but one of the other areas that I think is fascinating is the application on skin graft sites. One of the things from donor sites, for example, in the anterior lateral thigh, is patients complain of two things after you harvest the skin graft. One is pain, and the second is sometimes they bleed out through their dressings, and once that bleeding stops, it dries and crusts, and do a dressing change can be, again, painful. And so what ORC does by its very nature, it's hemostatic and it reduces pain or inflammation. So I think that is what's very helpful, and it's an exciting area for discovery. Now, if you look at ORC as general, you need it. It's a natural part of the human process of healing. And what you're doing with a product like this is you're essentially augmenting its purpose or to healing of the wound. And you look across the evidence across using this type of material, there's a lot of evidence. And unfortunately in wound care, as you all know, it's not really inundated with a lot of high quality evidence. And this is one of those few things that is. If you look at the number of clinical trials, there's been 12 published in this, over 700 patients in these studies. So it's been very well studied. And I just broke these out into some simpler graphics for DFUs, which is what we're talking about right now. There's 7 RCTs that include 491 patients that show good efficacy of this product. And you compare it to a control, for example. This is just one of the studies that is a level 1 study that was just presented that was on that list, 79% versus 43%. And so that's pretty impressive. There's very little evidence in many of the things that we do, but this is one of them. Let me give you some case studies here. This is a 52-year-old poorly controlled diabetic. And here we are after a ray resection. And just to be completely honest and disclose everything, I did try to close this primarily, but it didn't heal after the ray resection. So I'm left with this defect. And anybody that's done isolated central ray resections, that area always seems to be hit. And maybe there's just a lot of tension. I'm not sure why. But you had to go to something on an outpatient basis. It's not infected. It looks relatively healthy. I just need it to completely heal. And here we use Permogram Prisma. Here's a classic diabetic foot ulcer. Usually it's a plantar aspect. You can see it here. 45-year-old male, poorly controlled diabetic, 2-month wound duration. And you can see over the sequence of time. Now, you have to always mobilize or offload as well. And here I use this Prisma in conjunction with a total contact cast, and you can see the patient goes on to heal as well. I want to show you this study. This is a diabetic patient, but this is not a typical diabetic foot ulcer. Here's a patient that had HIV, Hep C, and a venous disease, and these look like venous ulcers to me. 9-month wound duration. So I decided to skin graft this patient. And here you can see the harvest site there, and I applied it right there onto the surface of the wound. You can see the skin grafting. You can see most of the wound is now covered, but there are areas that are not. And here it is blown up. You can see where those areas I'm still struggling to close, one on the dorsal foot, one on the medial ankle. So I started using Permogram Prisma, and over time you can see application every 4 days in this patient. You can see the patient goes on to heal. Here's a before and after of the dorsal foot. Here, before and after on the medial ankle. So that's on the outpatient basis, and I'll tell you, again, I've said this repeatedly, I think it's important for everyone to understand. I used to be the vice chair of research for MedStar Plastic Reconstructive Surgery. I'm a data hog. I look at the evidence and I look at it very critically. In this space, there's very little other biologics, drugs, or devices that has as much data to it as the ORC product that I just talked about. Let's switch gears now. Let's go into inpatient. Let's assume this chronic ulcer decompensates and gets infected. Now the patient's in the inpatient or admitted side. And I think this is where this device can be very helpful. This is negative pressure with installation. And for those of you who've never used this device, essentially what you're doing, you're marrying 2 different approaches. 1, irrigation of solution, and 2, negative pressure. You're marrying those together. And how it works is solution goes into the wound bed and it soaks for a period of time, and it's evacuated, the negative pressure is applied. And this you just program, and you can leave it on the default setting, or you can program to certain settings to your liking. when I was working at Georgetown, we had a very simple algorithm for care of these patients. And we were a surgical service, so we were heavily OR-based. And I think there's a solution outside of the OR that I'm going to talk about in just a few minutes. But essentially, a patient went to the operating room, then insulation was applied, and the patient went back to the operating room for perhaps the closure or coverage portion. Then the insulation was then lifted. We did this until we saw a couple things. One is we needed, if the patient was infected, we wanted to make sure the bacterial bioburden was low and it was well perfused, and then we were able to close or cover these things. But in between, it was about wound bed preparation, and that's where insulation therapy really helped. What we don't want to see happen is something like this, and I give this example, and I call this the Whittle effect, where this poor diabetic patient has had pieces and parts of her foot taken off over the course of many years. This Whittle effect, taking the pieces and parts, is not an economically prudent or efficient or effective method, because patients often return back anyway, because you look at those clinical slides on the left and right, the patient's not over this yet. The patient's not in a safe zone yet. And so this patient's foot is still at high risk. And if you look at the literature, hospital readmission rates, even after partial toe amputation, is 50% within 1 year. That's not a sustainable clinical model. Another way you can think about it, and I use this as an example. For example, I'm doing a nightly rounds with one of the interns on the service, and she says to me, this is Dr. Kim, this is Mrs. Smith. She's a 68-year-old diabetic female who's had history of bypass surgery, coronary bypass surgery, high cholesterol. And I just want to say, okay, you don't need to tell me how sick this patient is. I can count the number of signs on the door to tell me that the patient's been hospitalized either for a very long time, or the patient has been hospitalized repeatedly over time. Either way, that's a bad signal. I think this, again, is not the way we want to approach it. Just as an aside, when we talk about these signs, I just want to bring this to attention, because when we talk about efficiency in the hospital, this exemplifies something that is confusing to me. Just like wearing the silly yellow contact precaution precaution gowns that are perforated. Here we have a high-risk sign, and if somebody can tell me on the right-hand side what a low-risk fall means. And again, this is overthinking a problem and trying to provide barriers to efficiency of care versus creating more efficient care. Here's some examples of a diabetic foot. Again, it's got, it looks like to be an infected forefoot, and you can try to single stage this, but I think for us, we want to make sure the bacteria is cleared, so we'll incisionally debride, irrigate with instillation therapy, and then close primarily prior to discharge. I think that's a more efficient process. Here's another example of a dorsal and plantar foot wound, and the patient required multiple incision and drainage procedures due to heavy bacterial contamination, if not infection. And then we filleted that hallux with a skin graft on top after instillation therapy has been done prior to the final closure procedure. And here you can see a healed transmetatarsal amputation with the skin graft. If you look at the evidence across negative pressure, there's been a lot published in this space. Another way to visually look at this is, since its introduction in 1994, the number of publications up until about 2005, 2006 was pretty low. And then all of a sudden you see this spike in the number of publications because the pivotal study was published in the Lancet looking at negative pressure. Then you see another spike in 2011 to 2012 when negative pressure went portable, and I think that was a major innovation. And then the third arrow denotes where installation and incisional negative pressure comes to the forefront and becomes very important, and people start to take notice and people begin to publish more on it. When we talk about installation, this is one of the first studies ever published, which was the study that Larry Lavery ran, where he did a live pig lab where he wounded these pigs, inoculated them with Pseudomonas, and then looked at bacterial counts with the application of negative pressure therapy with installation with either saline or PHMB. PHMB is very interesting. It's polyhexanide with betaine, which is an antiseptic surfactant solution. And at the time when we're looking for solutions, I scoured the literature on antiseptics, and I really felt like this was the best one out there. So I said, oh, well, we need saline as a control group for a solution. But it turns out saline did pretty darn well as far as reducing bacterial count. Both were better than standard negative pressure or control. This is Greg Schultz's work down at University of Florida. He runs an ex vivo mature biofilm model. And he showed, again, that instillation therapy was better than standard negative pressure, but in his study, normal saline did not reduce CFU counts very much, whereas PHMB did. I think this is an important pivotal slide as well, because one of the comments that I got very early on when using instillation therapy is that perhaps our results were as good as they were because we were doing intermittent therapies. You think about the original Moriquaz, Argentis work, Dennis Orgil's work, the intermittency is the key to the success of granulation growth and the conversion of a wound to a healing state. But in reality, most people don't do it that way. Most people do continuous therapy. And so this is a pig study that shows that instillation therapy showed greater degree of granulation growth than continuous or intermittent therapy alone. There are two papers that John Lantis published out of New York talking about bioburden or bacteria. And this is a day 0 to day 7 study comparing instillation therapy versus that of standard negative pressure. And it's really interesting. The instillation group showed a decrease in bacterial bioburden, whereas the standard negative pressure group, the bioburden actually went up. Now, I have to be very careful when I say that because people misinterpret that to say, well, there's more infections in negative pressure versus instillation, and that's not true. That's not what I'm saying. What I'm saying is that if you go back in the advent of negative pressure, I would argue that the host was much different back then, even 20 years ago. I think the hosts were less challenging than what we're facing today. The bugs were less challenging than what we're facing today. So the patient's complexity of the patient is increased and the complexity of the wound is increased. So now we have something that's better, where I suggest it's instillation therapy. This is the second part of the study that he published as a follow-up to the first paper. It essentially says the same thing. With standard negative pressure, the amount of bacteria here in colony-forming units dropped with instillation therapy versus standard negative pressure where it did not. Now, if you go back to that Lancet paper, remember what I mentioned back in 2005, and you look at the adverse event profile, you can see clearly that during the course of the study, the negative pressure group had a higher number of wound infections than the control group. Now, I'm not saying this was not statistically significant, I don't think. I'm not saying that, again, it caused infection, but I'm just saying that now we have a tool that's even better than standard negative pressure. We have instillation therapy. This is Luke Teo's series of 131 wounds, and he showed a 98% closure rate on a variety of wound types, including diabetic foot ulcers using instillation therapy. This is Burkhard Lehner's paper looking at salvage of total joints, also showed a higher percentage of salvage acutely and chronically infected total joints using instillation therapy versus that of the published literature. This is our first study, and this really, this is published in PRS, and this really embarked us on a journey in understanding this therapy. If you fast forward from when this was originally published, over 8,000 patients have received instillation therapy at a single institution alone. And if you break down this data, it was really interesting to us because we compared negative pressure, standard negative pressure, with that of instillation therapy, and all those surrogate outcome endpoints, including number of operations, length of hospitalization, time to final surgical procedure, all of those were superior in the instillation group. That's what really converted us as the standard of care at Georgetown. Now, perhaps what I just said is biased and you don't believe me. Let's go somewhere else. This is Alan Gabriel's work. Looked at almost the same variables that we did and also demonstrated a decreased length of hospitalization, decreased number of OR visits. And I think that obviously translates into a decreased overall cost. And more important for me, I think it's, again, the hospital is a dangerous place. If you can get them out quicker, I think that's a better thing. Maybe Alan Gabriel is not somebody you want to believe either, so let's go somewhere else. This is Mike Timmers. This is an open fracture long bone study, also showed a decreased number of operations, decreased length of hospitalization, and decreased 30-day readmission rate using instillation therapy versus conventional therapy, which included in some numbers standard negative pressure. What you really want to see is a multi-center randomized prospective study, and that was done. This was led by our group at Georgetown, over 6 academic institutions, 200 patients, And those results will be published very soon. I don't want to let the cat out of the bag, but I'm very excited about the bacterial story that it tells. Now I want to show you the detergent aisle at your local store. And the reason I bring this up is some of the questions that I had received regarding this therapy is, what is the ideal solution for this therapy? If you look down your local store looking at the detergents, the laundry detergents, you actually read the ingredients, there's really not a lot of difference in what's in them. So it got me to thinking, perhaps it's not about the laundry detergent, but about the washing machine. And I think the installation therapy is exactly that. But to test my theory, I conducted a prospective randomized trial comparing normal saline versus PHMB. Remember the polyhexanide with betaine. And I looked at the same surrogate outcome endpoints that we've been looking at all along, length of hospitalization, number of OR visits, and so on. And there was no difference in those things. The only difference was time to final surgical procedure actually favored normal saline. And this is why when people ask me what kind of solution should I use, I say whatever you want. If normal saline works, then what you probably have works well as, may also work as well. But the only caution I would say is if you're using something like, for example, Dakin solution, I would recommend if you're going to use installation therapy for a longer period that you convert within the first 48 hours to normal saline. So for example, if you first see the patient, you start them on installation therapy, start them on Dakins, but only do it for 48 hours and then convert to normal saline for the rest of the time. I think that's a safe and effective method to go forward. There's been a lot of consensus panels published. I'm not going to belabor it. I'm going to stop on two things. One, indication. People are still confused on when to use installation therapy, and it's pretty simple for me. If the patient's in the hospital, the patient's complex. If the patient's in the hospital and it's a complex patient, then a wound on their body is complex by its very nature. Don't worry about categorizing to surgically dehisced, to venous, or diabetic. If it's a wound that requires hospitalization in a hospitalized patient, it is complicated by nature. It's complex by its very nature, and that's a good indication. How about number two is, this was something that we wrote many years ago in 2014 or so. I guess that's not that many years ago. Feels like a decade ago. And we said, it does not replace debridement. This therapy does not replace debridement. And then this novel foam construct came on the market, and this is something I call the waffle foam, these large pore size foam constructs. And I was at first very sort of confused by this. I didn't understand why you would punch holes this large in this kind of construct. And here's an example of a lateral foot. And honestly, I used it and I was not overwhelmed, meaning I was not that impressed. I said, well, I was getting those same results with installation. It's not that much better. Then we were faced with a patient like this. This is a sacral ulcer on a patient in the ICU. It's a very sick patient. And what do you do with a patient like this? You essentially have two options. One, you can use packing, which is what a lot of people do, whether it was Dakins or acetic acid or whatever you want. But if you write for example, BID dressing changes on a patient like this is a very resource-intensive activity. In fact, for this patient, it took about an hour to do each dressing change. And that's very difficult, especially in a setting like ICU when you're one-on-one or one-on-two. So how about this wound in the context of installation therapy with this waffle foam? You can see there, no sharp debridement, no sharp instrumentation has touched this wound, and you can see how much better in appearance it looks. Here's an ischial sacral ulcer as well, and here we are day 5, day 10. You can see how much of that necrotic tissue, and we sort of did this as a challenge, was able to be removed using this novel foam construct. It was pretty impressive. This is medial thigh calciphylaxis, and you can see here the vast improvement using installation therapy with this novel foam. Now, how does it work? And this is where I have to be careful with my language, because this is, again, off-label language anyway, but I think it actually debrides, where the tissue is sucked up into these big holes and then literally cut. But it needs to be used with installation therapy because the solution solubilizes the non-viable tissue, and it's able to cut and remove it through the egress line. And so I think that's how it works. And by the way, it's very early on this, but I will tell you, I really believe this is a game changer. This fundamentally changes how you approach the wounds. I think you can do things faster. or in the absence of good surgical debridement, or if the patient is too sick or refuses. I think there are lots of options for using this kind of construct, but the evidence is early. I think this is one of the very few papers published on this that shows great promise, but again, just a case series. Here are some recommendations that you can get from your local KCI rep. I think this is the last slide. I'm going to stop after this, but I want to talk to you about this slide. It's an important slide because it summarizes all the concepts that we talked about. Cost is up and down, effectiveness left and right. Top left, things are more costly and less effective. You know, that's really the world that we lived in, again, south of the border of the United States, and perhaps this box fits well for us. For you guys, I think having had an opportunity to visit and speak to people up in Canada, both nurses and physicians, I think you guys largely live in this box where things are less costly and less effective. That's not ideal either. Really, you don't want to be in the top right box either. You want to be in this bottom left, bottom right box where things are less costly, more effective, and provides more efficiency in the delivery of the healthcare system in which you guys practice. These are those three drivers of care that I talked about earlier: economics, efficiency, and effectiveness. And if you think about the wound care space, you know, there's a lot of dressings out there. There's a lot of different devices and biologics out there. But I will tell you, being, you know, putting your critical hat on, putting my critical hat on, I really can't identify a lot of products that fit so nicely in this box. And when you think about the total cost of care, and that's really Canada, that's how you guys sort of function. You have this total cost of care model. It's not like here where you're charging and billing for a certain procedure. I think that it's a different kind of model that you guys practice. I think that if you think about those and not in silos, where the total continuity of care is covered for that patient, and you think about it coming out of the same bucket, there are very few things that fit so nicely, and instillation therapy is one of them. All right, I'm going to just field some questions now.
Great. Thank you so much, Dr. Kim. And just as a quick reminder, there is still time to submit your questions. So you can type your questions into the questions pane, which is located at the bottom of your control panel. All right, our first question is a two-part question. Dr. Kim, thank you for a very informative presentation. I gathered from your talk that VeriFlow is your standard of care more than VAC. And the first part of the question is, how were you able to convince your administration and colleagues to use VeriFlow on your everyday wounds? In our institution, it is used only in large, complex wounds. And the second part of that question is, how do you address the concern that VeriFlow costs more than VAC?
Yeah, and those are great questions, and they're not easy to answer because I think it depends largely on your local circumstances. But as I discussed throughout my lecture, you have to think outside the bubble of silos. I think it's very important to understand the total cost of care for this patient. And it starts with evidence. And honestly, when we started using this and it wasn't our standard of care, we used negative pressure as our standard of care for decades. So when we were faced with the same challenge and the question that was asking, we said, hey, we've gotten some good results with this. We want to start looking at this, and perhaps we wanted to replace what we currently did. We got pushback as well and said, why would you do that? You've used negative pressure, standard negative pressure for many years. Why would you change? And so what we did was at that time, we're like, okay, let us study this. And then if it is indeed better, then we want to do the conversion. And again, for disclosure purposes, the two studies that I showed you that were published out of Georgetown were not funded in any way by KCI. Those were independent studies because we were exploring the therapy. We wanted to know if indeed it was better or not. We came in with a very open mind. So we went back with data to say, look, and I think there's where you guys have an advantage now is now I just showed you 3 papers that I picked out that tell an economic story where we talk about length of hospitalization, number of OR visits, and all of that. Now you have 3 different institutions telling the same story that's been published. So I think you guys have a little advantage that we didn't have because there was nothing. There was really nothing. Maybe there was 1 paper that was published on the topic at the time. And so it is a slow and methodical process, but I think when you believe in something, you've seen the results, I think it becomes then it becomes a standard of care. But one of the things, the other part of that is you asked a very complicated question. There's a lot of pieces to that. The other piece is, what I see people do is they reserve the most difficult and challenging cases for instillation therapy. This is the 98-year-old who has like 2 days to live. Let's slap this on and hope for a miracle. It just does not make sense. My recommendation is this: pick patients that are perhaps not as challenging, because what will happen with your comfort level as it increases, you're going to start pushing the boundaries. And that's what we did. We started with low-hanging fruit, and then we went more and more complicated and more complex. Now there's no limits. And that's what's going to happen with you guys as well. But don't try to isolate the most difficult person in your hospital to be your first placement. It shouldn't be like that. You should try it the less complicated, perhaps. And again, as I talked about, these are all complicated, by the way. If they're in the hospital, they have an open wound, there's a reason why they've got a breakdown in their skin. So I would argue that there's no exception to that rule in the hospital space. Next question.
All right, thank you, Dr. Kim. Our next question is, we experience the occasional leaks with Veriflow. How have you managed to educate all of your staff to apply perfectly?
Yeah, I think that's a great question. I'll tell you, maceration can happen, but it doesn't have to happen. I think and what we saw was no increase in maceration that we had with instillation therapy versus standard negative pressure. I think it's still technique-based, and everybody that I've talked to who've been doing wound care for a long time that work with standard negative pressure, they have their own technique. And I think you continue to adopt whatever technique that you're very comfortable with. I really like the door framing and window painting technique. That seems to protect. But if you want to use an Eakins ring, you want to use Duoderm, there's lots of options if you are concerned that there's going to be leaks. But I'm not, I think early on our experience was that there was an increase in leaks because we were oversaturating the foam. So initially, and this is another suggestion I have for you all, is that if you're using volume, if you're trying to figure out how much volume to use, I think as a general rule, less is better. And what I mean by that is when you start to fill a cyst, you watch it and hit stop. When you push down the foam, there's regurgitation out the lily pad, when the foam turns a darker color, you can visibly see it. And then you hit stop. When you back down 20%, I think it overestimates the volume. And I think that's one of the reasons people had maceration and leaks and all that stuff. As you fine tune your technique, just like you did with standard negative pressure, but your learning curve is going to be less steep because you already have the basics of standard negative pressure. I don't think you're going to be as concerned about those issues as you might think.
Great, thank you, Dr. Kim. And the next question is, how can we get a copy of the International Consensus Guidelines?
Yeah, and that's a great question. And there's many versions of this, by the way. It's not just a physician panel, but there's nursing panels as well. And I would recommend that you can go through Wounds Canada. They'll have access to it. But if you can also go through your local rep or the KCI website. I think most of those are published there. But one of the things I will tell you about those, I think they gave a good, very basic understanding, and it's important to read all of them because what you'll see in sequence, and I would suggest reading the earliest ones first, and then it builds. You can see the sequence, how it builds with the knowledge that we've gained over several years. If you start with the last one that was published, I don't think it's going to be as helpful as if you read it as a book. Here's the beginning, and here's where we are. Now, we're not at the end yet. I think there is huge potential for this, including portability, some other issues I think can be addressed with this kind of device. But I think what you need to do is read the first paper, and I think it's 2013, I think 2014. And then if you look at yearly, there's some version of this being published. It's built on the growing body evidence over time.
Thank you, Dr. Kim. All right, the next item I have is actually more of a comment than a question. And that comment is, we have a participant that is currently using half and half sterile water and vinegar to treat a foot ulcer, and it seems to be working. Do you have any comments on that, Dr. Kim?
Yeah. So yeah, vinegar is my go-to. I love it. It's acetic acid is what she's talking about. And what I would recommend, if you're doing half and half, it depends on the kind of vinegar that she's using. So, you know, every kind of vinegar, for example, white vinegar or, you know, apple cider vinegar, there's lots of varieties, and the percent of the acetic acid is different for every one of those. If you look across the spectrum of those, what's available in vinegar, it's anywhere between like 3% to 24%. And the dilution that's optimal, if you look at the literature, is a 1% dilute acetic acid. And you can just do tap water. People are like, oh, you have to get normal saline or sterile water or whatever. You don't. Just use tap water. That 1% acetic acid will kill all the bugs in that water. There's not a lot of bugs in that water anyway. If you're living in Canada, if you're living in Africa, that may be a different thing. But if you're living in Canada, that water's clean. It's potable. You can drink. It's fine. So use tap water, dilute it to 1%. So that's 1 part in 10. I'm sorry, not 1 part in 10. 1 part in 100. Vinegar, if it is 100% vinegar, and it's not 100% acetic acid, and it's not, you're going to have to do a little bit of math, and just read on the back of the label. Will tell you percentage of acetic acid that's in that jar.
All right, thank you, Dr. Kim. And our next question is data. If costs and data drive care, where are we actually getting said data? We have numerous EMRs, very little high quality research.
Yeah, that's a great question. And that's a major frustration for me, because their perception is the randomized controlled trial is the highest on the hierarchy. It's simply not. I believe there needs to be national registries. If you look across Europe, the good data, really good solid data, are data that's in large volume, meaning having 100 patients is not enough. Having 1,000 patients is not enough. Having 10,000 patients may be enough. And the only way to do that in an objective manner is through a health system that is integrated with and tied with the government. And this is where I see such opportunity in Canada, for example. If you have a centralized EMR, there are aspects that you can pull from there. The problem is the instruments. Everybody may have some variability on how things are measured, for example, or how you conclude a wound is healed. Unless that's agreed upon, the definitions are agreed upon, I think you have real trouble understanding what it means, because if you have garbage in, meaning bad data in, you're going to have garbage out as far as to analyze, and that's not easy. And I think there have been some efforts of wound registries that are owned privately, and I have a real issue with that, by the way. I think if you have to pay to access that data, I think that's not good. That's not being, kind neighbors and sharing your knowledge. And that's why if you think it's a government-owned, perhaps there's a greater accessibility and more unbiased approach to see what treatments work and which ones don't. We're not there in the United States for sure, because we have so many privatized or nonprofit or not-profit or for-profit health systems. We're not as integrated as Canada is. I think Canada is where the real opportunity is.
Perfect. Thank you, Dr. Kim. And our next question is, are there any contraindications for Promogran or Promogran Prisma?
I don't think so. I mean, it's a pretty innocuous substance. I mean, I don't see any, I've used it over tendon, bone, ligament. I don't think there's any, I wouldn't put it in like grossly infected wound. If it's like a purulent pool and you want to put that in, I think that's a bad idea. But I see no, for me, again, I'm talking from my clinical experience. I'm not reflecting what KCI thinks. I don't think there is a contraindication for using that.
Great, thank you, Dr. Kim. And just as a quick reminder, there is still time. If you do have any questions, please do type them into the questions part of your control panel. All right, and our next question is, what contraindications exist to use of VeriFlow in community?
Yeah, and that's a very good question because, once you guys start getting comfortable, you're going to start pushing the envelope like we did, and sometimes you get into trouble. For us, I think it's the same things as VAC, but even exemplified even at a higher degree. If you have, for example, unexplored thoracic cavity or abdominal cavity, whether you have it penetrates deeper than fascia, then we're dealing with fluid that dwells. So be mindful that gravity is going to pull that fluid away. And if you have some nooks and crannies that have not been explored, I think that could be dangerous. I don't think there's any contraindications that is beyond that of standard negative pressure. Those principles are still pretty consistent. But I will tell you on the other side of that, where I find it really interesting for installation is in those cases where you're worried about desiccation. Remember, you're soaking with solution. So, for example, over capsule or tendon or ligament, which tends to desiccate and die very quickly, when it's exposed to air. I think what installation does, it allows you to do, is it hydrates that tissue because you're dwelling solution to that tissue. And I think there's a huge benefit of trying to salvage tissue that otherwise would become necrotic and desiccated. And so I think that is an opportunity where standard negative pressure just cannot provide. The other piece of it is people were always concerned about using negative pressure in contact with tissue for too long due to invagination of granulation tissue, and people rip it and bleed, painful, whatever the cause may be. Where installation is superior in that respect is because you're dwelling, there's a separation that happens within the foam and the wound base. So you're not going to get the indwelling or invagination of tissue that you did with standard negative pressure. And that also solves another logistical problem. When you use standard negative pressure, I've heard people use an interface dressing like a non-adherent dressing like a Mepitel or Adaptic as an interface, especially when there's tendon or exposed bone or capsule involved. And so they'll use this interface dressing. I've never liked that idea because what it does is it imparts a drop in negative pressure that you're imparting across the wound bed. So you're actually getting a pressure not at minus 125 like you've said it. You're probably under 100 millimeters of mercury at that point when you put an interface dressing. And then the pore size, which has always been told to us is important, is then obliterated because you have an interface dressing preventing those pores from actually being in contact with the wound. With installation therapy, you don't need an interface dressing because you're not going to get invagination. You're hydrating the tissue. It has clear advantages.
Perfect. Thank you, Dr. Kim. And our next question is, I was under the impression that Promogran was only to be used in granulating wounds.
No, in fact, I would argue the opposite. I think if you want to promote granulation, I think that is an option for you. And some people actually use that in combination with, for example, an outpatient negative pressure device. I think it is to promote granulation, and not only granulation. Remember, granulation is a sign of two things. One, low bacterial bile burden, and two, adequate perfusion. To me, it's not an end goal. It's not trying to get granulation tissue. All it tells me is that I've optimized the wound bed. It's going to go on to accelerate healing. The other thing that Promogran can do is accelerate epithelialization. That's a different thing than granulation, but it does both.
Great. Thank you, Dr. Kim. And we have time for one last question. And that question is, what about using sea salt dissolving in water instead of vinegar to promote wound healing?
Yeah, I don't know if you're talking about taking sea salt out of the ocean. I don't know how clean that is, but if you think about normal saline, that's 0.9% sodium chloride. So it is salt, it's salt water, and that's physiologic, if you will. And so I think that's fine as long as it's clean water and you have dissolved salt. But I'm not sure I recommend going into the ocean with it.
All right. Thank you, Dr. Kim. And that is all the time that we have today. So thank you, Dr. Kim, for your engaging presentation. And thank you, KCI and Acelity Company for sponsoring this very informative webcast. Thank you, everyone, for attending today's webinar, How Are You Managing Diabetic Foot Ulcers? Evolution of Therapies Across the Continuum of Care. The recording will be available on woundscanada.ca. On behalf of Wounds Canada and KCI, thank you for joining us today and have a great rest of your day.